Hey, I'm Dr. Bob Donatelli here again, and today we're going to talk about some really interesting components to this Formthotics system that I love. These are the components that make this a specific device, a custom device, a truly custom device, because we can add anything we want to help support the foot in different postures. For example, we have here one of probably the oldest methods of orthotic fabrication. They're called metatarsal pads. These metatarsal pads are used, for various things. I think probably the most common thing I use it for is to try to put a little pressure off the metatarsals, like if you have a neuroma between the second and third metatarsal. We kind of put this right in between those two metatarsals, and again, it kind of separates it out a little bit to reduce the effects of the neuroma, which is normally tingling and numbness in the web space of the toes associated with that entrapment of the interdigital nerve. So these are really simple to use, and again, all of these have adhesive backing. You just pull this off and stick it to the bottom of the orthotic. Really easy. This one is, again, very simply a hard arch support, and it goes into the arch, obviously. Again, I tend to this is a low-profile Formthotic. The other ones have a nice support in the arch. I tend not to use these as much, but they can be very beneficial in supporting the arch if you need more support to the arch. Then we just have simple, very simple heel lifts, for possible leg length discrepancies. And we have a short heel lift that just goes in the calcaneal area, and we have a longer one that has a more tapered off effect. Again, just for the comfort of the patient, really. These are probably for maybe a larger individual with a bigger foot, has a larger heel, so this tapers off a little bit easier. These are fairly, large, and they're also fairly rigid, so they are going to compress down a little bit. But we're not talking about a lot of leg length correction you can make anyway in the orthotic devices, right? So those are probably really the simplest of the components in their usage. Again, the metatarsal pad goes right in the forefoot area. Usually second and third metatarsals where you see those. A neuroma is basically an entrapment of the interdigital nerve and artery between the two metatarsals, and it forms a fibrous tissue around it that cuts off the nerve and the blood supply to some degree. It causes some numbness and tingling in the web space. Clearly a common symptom associated with that. That's what I use these mainly for that purpose. And the arch pad, the heel lifts, very simple, nice to have though in the clinic. Sometimes, people have a permanent leg length discrepancy or even a temporary leg length discrepancy. Or if you want to put the heel on a little bit of a slack, the tendon of the Achilles on a little slack, you can add this temporarily. I wouldn't do this permanently, okay? Not unless you have a true leg length discrepancy. Now, moving into these last two components, these are the ones I think that really benefit the patient and help to reduce pain, a lot of different symptoms that are to control pronation or control too much supination. So let me show you. There's two different kinds. Again, nice peel-off adhesive, self-adhesive. You stick it to the bottom of the shoe so we can make a wedge, right? And it can be either a rear foot varus post, okay? So we have, again, that's when the wedge is on the high side, is on the medial side of the orthotic. Rear foot varus post. Sometimes I like to clip off that little edge here, the corner, because patients complain about a little bit high feeling in the arch area. So you can just clip that off and eliminate that problem, right? But there's a nice rear foot varus post for those patients that have a lot of pronation, which means the calcaneus is moving into eversion, right? And we can support that nicely with that wedge. They have two different sizes. This is a much smaller wedge, as you can see here, right? Very nice design, easy to put on. You can also do a rear foot valgus post. So if you have somebody with a rear foot problem or a high arch patient, in other words, and the calcaneus is sitting more inverted this way, we push it this way to get it to do more pronation. And again, a very nice fit. You just put the high side of the wedge on the lateral side of the foot or the outside of the foot, as opposed to the medial wedge, again, which is on the inside of the foot. This, I really like this next one. It is a wedge, but it extends way into the mid-tarsal. This is the larger one. I think it's a little easier to see the larger one, but this is also the same thing. It's just a little smaller wedge. So with this, I just used this on a patient the other day with horribly flat feet. Her husband actually said she waddled too much because of her flat foot. It threw her gait off terribly, having pain, couldn't stand on her feet. She does stand on her feet like 7 hours a day. She could not last all day standing on her feet because of the pain in her foot. And she was having knee pain as well, developing. And so this is a nice support throughout the entire arch. Now see, I obviously wouldn't go to using an arch pad in here because that's way too much. But this is nice, and you do want to clip this off, right? She just came in today. I had to shave this down, have a little file, you know, that I can file it down. I cut that edge off, and then I filed it down smooth, and it got rid of all of her discomfort in this area. She felt like she had a lump in there. So we actually have close to, not quite, a 4-foot varus post, which we're going to talk about next. But you could do that. You can actually put this whole post on the inside of the foot. Now that's someone really, you're going to limit the amount of rolling in or pronation, right, if you will. As you can see here, let me put this up front. You can see if you have that, you see how it's tipping the foot out this way, controlling the amount of rolling in, because you hit that wedge, and of course it's on a hard surface in the shoe. But you can also cut this off and do a 4-foot post. So we can take, for example, you can either cut this or just take a separate one of these. One of the options I have with this lady, because she is so horribly pronated, is to take one of these now. If she comes in and complains of problems, we can do a 4-foot wedge. Okay, so it looks like that. We just have to cut this off here, this rounded surface. We can just cut that off and do a 4-foot post or wedge, right? Varus, which is meaning it's on the inside or the medial side. Medial wedge, varus wedge, same thing. You can see there's a little bit of support underneath that first metatarsal. And now we got a really controlling orthotic device. If I did this, I probably would cut this back a little bit and get it out of the arch area. Again, it just varies on the patient. That's what I mean. These are custom devices. You cannot send an orthotic off to a lab, you know, a cast foam box, whatever you're using, and expect them to be able to experiment because they don't have the patient there. I mean, this is a science to some degree, but it's also an art. Patients' complaint of pain is what we're trying to get rid of. Yes, we're trying to control pronation, but the goal is how much pronation do we need to control to get rid of that person's symptoms? No one really has an idea what that is. Because why? Everybody's pain is different. So we're trying to control the movement, and most of the time it's pronation. I mean, that's what I see the majority of the time in my clinic is overpronators. So they're rolling too much in, right, in this way. They're rolling in this way. So what we want to do is support the side of the foot to prevent them from rolling too much into that direction. You don't want to eliminate pronation because that's a normal part of the mechanics of the foot as you walk. And what these are doing is basically trying to control that movement. So I'm specifically trying to get rid of the pain. How much do I use? Well, I put these, I make the orthotics, I heat them up, put them in their shoes, they mold to a new posture. Their foot is in a new posture now, right? So if I'm wedged it out this way, it's now in a new position, and I let them go home with it as long as they're comfortable. They're comfortable, they come back here in a week or two after they're walking on it for a while, and they say, you know what, Bob, it's not quite completely gone. I still feel like it needs more support. So I might take this and again do a cut to make this a 4-foot varus post. Again, you just have to cut this little circle, half circle off, and you have a nice 4-foot varus post here. And I might cut this back a little bit, right, and just do a rear foot varus. So you have 4-foot and rear foot varus posts. The nice thing about the Formthotics is I can make corrections over and over again. I can add components to it when I need to. the best part about it is I can reheat this every single time the patient comes in. I can get a different mole of the foot posture, which I'm correcting, or changing, I should say, not correcting, changing by adding wedges, by adding a heel lift, right? By adding metatarsal pads, by increasing the arch stability. I'm controlling each part of the foot. This is the one I think I use the most, without a doubt, is the rear foot varus post, and now only really controlling the heel when the heel hits the floor, right? So the heel hits the floor, I'm controlling the calcaneus from not rolling too much in, and it goes through the rest of the gait, right? If I want to control the midfoot, I might add more to the arch. If I want to control the forefoot and push off, because I think it's unstable, I put a forefoot varus post there. This is the most common component that I use with most of my patients that are overpronators. And sometimes I just start off without any of these components. If I think that they're pronating but not excessively, I might just go with the orthotic alone and see how that does. And then I can start adding different components to control that excessive, I hesitate saying abnormal. I guess abnormal is related to the symptoms they're having. If you can correlate the symptoms they're having with the excessive movement in the foot, whether it be supination or pronation, then you have a treatment philosophy. I'm doing a thorough assessment, I'm listening to their pain, I'm using the orthotics with components to help reduce that symptom and control the excessive motion.